the second generation ones that have the same mechanisms, zanubrutinib and acalabrutinib, there was recently a randomized phase 3 comparing ibrutinib to acalabrutinib, and zanubrutinib has the same going on. For the ibrutinib, acalabrutinib, it was in high-risk patients that were relapsed refractory and was powered for non-inferiority, but the progression-free survival was the same. The hazard ratio was 1, and it was non-inferior. So the efficacy, at least of acalabrutinib and ibrutinib, seems similar, but the toxicity is less. So I think it is likely and is already happening with the other approved drug, acalabrutinib, where that is replacing use of ibrutinib for a lot of patients. Not all of them, because like ibrutinib is a daily dose, the other one's, twice a day, so there's some like minor differences that matter for an individual. So I do think zanubrutinib and acalabrutinib are likely to replace ibrutinib. The reversible ones, that's not yet clear. So drugs like pirtobrutinib, which I'm sure you've heard about, Arcul 531, there's a couple other drugs that are in development. Those have been studied in relapse refractory patients, and largely those that are BTK inhibitor exposed. So it's not yet clear that those offer an advantage that they should replace the initial ones. In fact, resistance to the reversible ones maybe would confer resistance to the covalent ones, so it might be better to sequence like the ibrutinib, acalabrutinib, zanubrutinib, whichever of those, and then go to a reversible one. So I don't know that the kind of new type of BTK inhibitor is yet going to move up to that point. And I know as we get more data, I'm very certain it will be studied early in the disease course as first-line therapies, et cetera. But I don't know that the goal is necessarily just to straight up replace those with a different mechanism BTK inhibitors.